The purpose of this lecture on the renal system is to take a closer look at glomerular and tubular pathologies. The main topics we'll talk about are the processes and the etiologies of nephrolithiasis, kidney stones. We'll also differentiate primarily between the glomerular and tubular pathologies, and we'll talk just a little bit about how vascular pathologies play into that. And then we're going to take a closer look at and be able to compare and contrast nephrotic and nephritic syndrome. So let's start off by talking a little bit about stone disease or nephrolithiasis, even urolithiasis, and whether it's nephrolithiasis, which would be in the kidney itself, or urolithiasis, it's that stone has now passed into the urinary drainage system. These are important concepts. We know that for the most part, nephrolithiasis or urolithiasis is something that happens as we are adults. However, we're seeing an increased incidence of kidney stones in the late teens, and especially in African American females. Kidney stones occur distal to the collecting ducts, and the size and the location actually determines the physiologic impact. So very small stones may never be manifested. There may be some small stones there that the individual develops but consistently passes. Some people would call this sand because it's very, very small. The size of the stone really does make a difference, though, because stones that are less than 5 millimeters in size are more likely to be able to exit the urinary system without intervention. However, something greater than 1 centimeter is unlikely to be able to get itself through the urinary system and be able to be passed. When we think about what a kidney stone actually is, it's a supersaturation of salts or minerals within the urine. And what happens is these salts, these substances actually precipitate and form crystals. When these crystals come together, those precipitates and these crystals come together, they actually become a calculus or a stone. So they all come together and they form this complex of a stone. And that stone has a knobby appearance, so it has little sharp edges. So it's not perfectly round, like it's not like a river pebble. It's more like something you might find in your garden with gravel in your soil. Now, what's interesting is if you live in the southeast, and certainly Texas, we are actually in the stone belt, and we're in the stone belt because our soil, as well as our water, tends to be fairly high in calcium and phosphates. The other important piece in the pathology of these supersaturated salts is that individuals that tend to develop these stones don't have inhibitors to the development of those stones. So some of the inhibitors to stone development include potassium citrate, and magnesium. So it really is all about the substances coming together. And these stones actually become embedded in a mucoprotein matrix that then continues to allow them to grow, develop, and cause trouble. Now, when we look at the composition of most stones or most calculi, the vast majority of them are calcium oxalate or phosphate, about 70-80% or so. The second most common type of stone is a uric acid stone. Now, there are two primary ways that an individual may develop uric acid-based stone disease. One is if they have a diagnosis of gout. Gout is an alteration in purine metabolism that makes it easier for them to precipitate that uric acid. The other place you might see an individual with the development of uric acid stones is if you work in chemotherapy, especially giving ablative chemotherapy. In ablative chemotherapy, we are killing huge amounts of cells. And of course, those are the cancer cells primarily. But you have to remember that uric acid is an intracellular substance. So when you kill huge amounts of cells with an ablative chemotherapy, that uric acid becomes released into the circulation. Once it's released into the circulation, it presents itself to the kidneys. The kidneys then filter it out, and they begin to form crystals within the collecting system. The third most common type of stone is a struvite stone. Now, these aren't as common as uric acid or calcium oxalate or phosphate, and a struvite stone is actually made of phosphate, magnesium, and ammonium. So different kinds of substances, different kinds of stones. Because the vast majority of stones that individuals have are calcium oxalate or phosphate based, we know that alkaline urine encourages most of these common stones. So if someone has an alkaline urine, a pH of the urine greater than 7, that encourages the growth of these calcium oxalate and calcium phosphate stones. However, uric acid stones actually grow best in an acid environment, so there are some differences there. When we think about the manifestations then about nephrolithiasis or these kidney stones, for the most part, the manifestations of this pathology either relate to when the stone is on the move or when it chooses to obstruct the pathway, the drainage pathway. So when we think about a stone that is on the move, this is where you'll get the symptoms of renal colic. So when a stone forms and it begins to pass through the urinary system, it causes referred pain. And with renal colic, what we're talking about is flank pain that generally radiates to either the groin or the labia, obviously depending on your gender. By the time someone has this renal colic, though, even though we call it renal colic, the stone is actually in the ureter and it's on the move. This pain is frequently associated with nausea, abdominal, and vomiting. Now, the other thing that matters is the size of the stone. As I mentioned earlier, if a stone is smaller than about 5 millimeters, it has a pretty good chance of passing through the system. However, as it gets bigger and bigger, it becomes less likely to be able to be passed through the system. Those ureters can only dilate so much to let a big old stone get through. In some cases, these stones actually develop in the renal pelvis, and that's called a staghorn calculus. If you remember the collecting system, there's that renal pelvis is the part where all the drainage systems from the kidneys come together before you enter the ureter. So a stone can actually form proximal to where the ureter begins to leave the kidneys, and it can completely obstruct one of the kidneys. Generally, stone disease, although they may form bilaterally, usually by the time one gets big enough to get on the move, it's frequently a unilateral process. So what about this idea of protein in the urine? Protein in the urine is an incredibly important concept when we look at kidney disorders, because we know that protein in the urine, except for small amounts, is not a normal finding. So when we see protein in the urine, we are looking at either primary kidney pathology, where the kidneys are actually being horribly damaged by primary disease, or it could also be that the kidneys are under stress from a systemic disease. For example, you may see small amounts of protein in the urine during an acute febrile illness. You can see protein in the urine as a component of heart failure. And as you relieve the stress off the heart, the proteinuria will tend to recede or completely go away. But when they have another exacerbation, there's protein in the urine again. I think I mentioned it previously on one of the other ones, that protein in the urine is really seen as a canary in the mine. And what that means is the protein in the urine is a manifestation in the kidneys that the system is under stress. And so you're more likely to see protein in the urine. Now remember, again, under usual circumstances, protein, which is a very large negatively charged particle, is not filterable by the glomerular membrane. Now, small amounts of protein represented as albumin, because that's a smaller molecule than the protein itself, that's usually the way this protein shows up. So as you can see, and again, I don't expect you to memorize these numbers, but what I do expect you to memorize is the idea. So it's okay to have a small amount in protein in the urine, but we monitor that over time. So let's say someone comes in with 30 or 35 milligrams per deciliter of albumin in the urine. We're going to check that again to make sure that it isn't going higher and higher and higher. As that protein goes above that 300, but before it gets to half a gram, we say, well, this is significant. We need to keep our eye on this, because and you're going to start looking for what is causing the protein in the urine. We also then talk about, as that protein gets higher and higher, we talk about nephrotic range protein. Generally, when an individual has more than 3 grams of protein in the urine in a day, we call that nephrotic range protein. Now, as this gets higher and higher, we look for a glomerular pathology. When it is lower, it could be either a developing glomerular pathology, or it could be representative of tubular disease. In general, tubular disease, the levels of protein in tubular pathology tops out right around 2, maybe 2.5 or 3 grams. In glomerular disease, you can see 4, 8, even 10 grams of protein in the urine. So you know they're using huge amounts of protein in the urine. So that's why we characterize the amount, even though we call it nephrotic range. It's important, and I would expect that you would be able to determine the level of tubular versus glomerular protein in the urine. We also look very closely at the albumin to creatinine ratio. And generally, again, there should be less than 30 milligrams of albumin per 1 gram of creatinine. And we do this on a spot urine specimen, and it actually approximates and then extrapolates the amount of protein that would be, or protein albumin, that would be in a 24-hour urine specimen. Again, remember that in general, protein and this albumin isn't in the urine because it's a large molecule and it is negatively charged. The basement membrane that it has to cross is also negatively charged. That's why normally you don't see protein in the urine. Interestingly, most of us in our daily diets take in a fair amount of protein in our diets. Physiologic intake of protein is 0.8 grams per kilo per day. When we take in very large amounts of protein, protein can actually be a vasoconstrictor within the kidneys. So let's turn our attention then to some kidney pathologies. We're going to talk about glomerular and tubular interstitial. The piece with vascular is that there can be a vasculitis within the vessels of the kidney, usually the glomerular vessels, and you would see that in inflammatory markers. Certainly when we talk about hypertension and chronic kidney disease, that does represent a vascular pathology, and we look for damage to the glomerulus because of the atherosclerotic process that the hypertension causes. So vascular can be secondary due to hypertension, or it could be a vasculitis due to an inflammatory process. And there's some overlap between these strict categories, but we're going to talk primarily about glomerular and tubular interstitial. So let's start by talking about glomerular disease. Glomerular disease pathologies may be inflammatory, may be primarily inflammatory, or may be less inflammatory. And I'm going to call that non-inflammatory because you don't get that big inflammatory reaction in etiology. These diseases can be primary or they can be secondary. A primary glomerular disease, the disease affects the kidneys first. In a secondary glomerular disease, this affects the kidneys second. So this is frequently a complication of another disease process. Again, remember that the capillary bed is a selective semi-permeable membrane, so that when we're looking for the pathology, we're looking at how this pathology is affecting that glomerular membrane, especially the basement membrane. When we see glomerular disease pathology, we're looking for injury to the endothelium, absolutely the basement membrane, and the podocytes. Now the podocytes are little slit pores or gaps that are in the membrane. And when those slit pores become damaged, the pores or the gaps, not the slit pores, but the podocytes rather, become damaged, those pores or gaps become wider or greater. And that tells us that the membrane has been damaged. We know that glomerular disease can be acute or chronic, and we also know that whether it's acute or chronic, we're looking for common manifestations that signal the glomerular disease. As we just talked about, we're going to be looking for protein in the urine. And in glomerular disease, remember, we're going to see very large amounts of protein, large amounts of albumin in the urine, larger than in tubular. Hematuria is not terribly dramatic in a glomerular disease. Generally, when we see hematuria, it tends to be a relatively small amount and is not frank hematuria, meaning you don't see bloody urine, but you'll see the breakdown of red cells. And last but not least, urinary sediment, abnormal cells that when the kidneys are healthy, you would not see these abnormal cells or this abnormal sediment within the urine specimen. Because of the changes that the glomerular disease tends to make, we would be looking for oliguria, which would be a decrease in the urine output. Because of the loss of protein in the urine, we would be looking for edema. Now remember, part of the edema is due to the loss of protein in the vascular space. So you've lost your plasma oncotic pressure. Fluid is going to move from the vascular space then into the interstitium. However, remember that the other thing is going to happen here is when you start moving that fluid into the interstitium, you will also stimulate the renin-angiotensin-aldosterone system, which then stimulates the reabsorption of sodium and fluid. The individual frequently presents with hypertension. Again, RAS would be a major player there, as well as azotemia. Now, azotemia is a descriptive term. It's not a diagnostic term, but it is a descriptive term. And azotemia means that there is an increase in the plasma urea nitrogen and the plasma creatinine, because these are waste products of metabolism that the kidneys should be able to get rid of if they are not damaged and if they are not diseased. So again, that injury to the basement membrane becomes key, because in a glomerular disease, the negative electrical charge across that membrane has either been lost or the filtration pore size, those slit pores, those pores have a bigger gap, and as a result the proteins are entering the filtrate, and because these proteins are large and they are still negatively charged, they cannot be effectively reabsorbed in the tubular mechanism. So as we take a closer look then at some glomerular diseases, let's look first at some inflammation-based glomerular diseases. So a couple of things that we want to think about in the inflammatory disease states that affect the kidneys. There are basically two different ways that the inflammatory process affects or really gets to the kidneys. So one is you have circulating antigen-antibody complexes that have already been formed in the circulation. They get to the glomerulus, they present themselves to the glomerulus, and then you start they essentially get stuck. Those complexes get stuck in the glomerulus. They're trapped, and they begin to damage the glomerulus. And this is what we talked about in hypersensitivity reactions. This is part of what you'll see in lupus nephritis. Because remember, in lupus nephritis, you have circulating antigen-antibody complexes that then become systemic. The negative systemic effect on the kidneys is to stimulate glomerular damage. But you can also have something called in situ damage. In an in situ inflammatory disease, the antigen is the glomerulus, or the antigen has already been planted in the glomerulus itself. So think of it as the antigen is just sitting there in the glomerulus. Either it got stuck, it was placed there by the circulation, or the body sees the glomerulus itself as the antigen. Then what happens is circulating antibodies that are already present in the body react with that antigen. That circulating antibodies come in contact with the antigen that is placed in the glomerulus, or that is the glomerulus. So now we're back to that inflammatory cascade that we have talked so much about in other lectures. That there, because of that initial inflammatory injury, because of the antigen-antibody complexes or the antibodies reacting with the antigen, this activates complement, and the cascade in that whole inflammatory cascade is initiated and then continues to progress. As that cascade progresses, there is damage to the basement membrane of the glomerulus, and it begins to break down. When you break down that basement membrane, you decrease the glomerular filtration rate. It isn't able to do its job. So the end result of these antigen-antibody complexes, or the circulating antigens reacting with an antigen in the glomerulus, the glomerular basement membrane, the end result is damage to the glomerulus. With that comes an increase in the membrane permeability. Those cells will begin to proliferate, and as those cells proliferate, they become sclerotic. When you have sclerotic basement membrane cells, that wall becomes thicker and thicker and thicker, which then decreases the glomerular filtration. So let's look more closely at some specific pathologies. Remember, I mentioned that glomerulonephritis can be acute or it can be chronic, and I've pulled out three of the three sort of differences to take a look at. The first is IgA nephropathy. With an IgA nephropathy, this is a proliferative glomerular injury and sclerosis. This is due to circulating complexes that present themselves to the glomerulus. And these circulating complexes, part of that is the IgA as opposed to an IgM or an IgG or an IgE. This is much more common in children and generally occurs 24 to 48 hours after either an upper respiratory infection or a GI viral infection. A membranous glomerulonephritis is an IgG-mediated acute glomerulonephritis, and this actually is one of the most common types of a glomerulonephritis. IgG is either formed in or is presented by or is in circulating antibodies that present themselves to the kidneys. These then react with podocyte antigens. When they react with those podocyte antigens, again, what has happened? You initiate that inflammatory cascade and the inflammatory response because these complexes that have formed activate that complement. With a rapidly progressive glomerulonephritis, the individual actually has antibodies to the basement membrane as well as the neutrophil cytoplasm. So this is a rapidly progressive glomerulonephritis is not as common as the previous two. It is more common in elders, and as we get older, not as we get older, we're not likely to develop it, but you rarely see RPG, or rapidly progressive glomerulonephritis, in a child or a young adult, generally in someone who's older. But what this rapidly progressive nephritis occurs, you have IgG deposits along that basement membrane, and that glomerular membrane begins to proliferate, and it can invade the Bowman space. Remember, Bowman space is that area that is continuous with the tubular system. When that happens, it actually develops specific little cells called crescents, and that's what we look for on the biopsy. Rapidly progressive glomerulonephritis used to be called crescentic glomerulonephritis, because that's what we always saw as we were learning about this disease. That's what we saw when we did the biopsies. Now let's go back to this idea of the antibodies not only to the basement membrane but also to the neutrophil cytoplasm. And what shows up here, the specific antibody is anti-nuclear cytoplasmic antibody, or ANCA, A-N-C-A. This ANCA, this antibody, actually destroys the membrane without necessarily making immune deposits. This is one of those diseases then that causes more of a vasculitis. It's associated with a vasculitis. So what about chronic glomerulonephritis? Chronic glomerulonephritis isn't associated with the kinds of things we just talked about, the IgA or the IgG. In a chronic glomerulonephritis, this is a nephritis that develops over time and has the ability or the tendency then to develop into a nephrotic syndrome. So it continues to foster glomerular basement membrane damage over a longer period of time. Also, the injury of a chronic glomerulonephritis doesn't remain confined to the glomerular structure. The injury extends into the interstitium of the tubule, and that's a key piece and difference between acute and chronic glomerulonephritis. The second thing is the long-term nature of chronic glomerulonephritis. In an acute glomerulonephritis, the process is potentially reversible. Rapidly progressive is very difficult to reverse, but it can in some cases be reversed. But acute is potentially reversible. Chronic is long-term, rarely reversible. A chronic glomerulonephritis is frequently secondary, and as I said, tends to lead to nephrotic syndrome over time. Two of the pathologies that can lead to a chronic damage of that basement membrane is lupus, because of the autoantibodies and deposits in the glomerulus, as well as diabetic nephropathy. Diabetes-related nephropathy is due to the glycated end products of incomplete glucose metabolism. These glycated end products set up a inflammation-like process, and elevated blood sugar over time also fosters widespread inflammation. A key thing to think about when we talk about glomerular and tubular diseases is the difference between nephrotic and nephritic syndrome. Now, this is not, nephrotic and nephritic syndrome is not specifically a diagnosis. It is, however, extremely descriptive. And that's really the way I think it is helpful for us to think about nephrotic and nephritic syndrome, because usually then we start looking for what causes this nephrotic range protein or the nephritic range protein in the urine. So when we look at nephrotic, frequently again, this is not a strictly inflammatory process. This is what you'll see in diabetes, hypertension. Hypertension has an element of this as well, as because of the vascular damage, and amyloid disease. Generally in nephrotic in a nephrotic syndrome, you have a large amount of protein in the urine. How much protein? Yes, usually more than about 3.5 grams per day. However, not all individuals with that much protein in their urine develop this syndrome. So they may put out a fair amount of protein in the urine, but they don't always develop this nephrotic protein syndrome that we're going to talk about. So this nephrotic syndrome, in addition to the amount of protein that's in the urine, is characterized by edema and elevated lipids. So let's think about the edema. As we talked about before, in this nephrotic syndrome, the key is damage to glomerular permeability and the permeability barrier. Because of that damage, then, the protein is entering the urine. The protein in the albumin then within the vascular system are beginning to drop. Like we've talked about before, that's going to decrease the oncotic pressure and stimulate the renin-angiotensin-aldosterone mechanism. The edema that you'll see in nephrotic syndrome tends to be both peripheral as well as central. So when you look at someone with nephrotic syndrome, you'll see that dependent peripheral edema, but you'll also see anasarca. You'll see that development of and the collection of fluid within the abdominal space as well. And again, it's because of the loss of the albumin as well as the fluid retention due to the sodium. Individuals with nephrotic syndrome, when their serum albumin decreases below 2.0, they have a very high risk of an embolic event. And they carry this high risk because of an increase in platelet aggregation and decreased thrombolysis which occurs with very low serum albumin levels. The second thing that you'll see in a nephrotic syndrome is elevated lipids in the serum, as well as you may see lipids in the urine. So how do the lipids play into this? In nephrotic syndrome, there is an increased production of lipoproteins by the liver. At the same time, there is a decrease in the metabolism of lipids. Specifically, the lipids we are concerned about are LDL, low-density lipoproteins, the total cholesterol, and triglycerides, and we know those are all elevated, tend to be elevated in a nephrotic syndrome. We also see an elevation in lipoprotein A. So remember, lipoprotein A is highly atherogenic, and because of that, individuals with nephrotic syndrome carry an increased risk of MI as well as an increased risk of cardiac death. In the urine, what would we be looking for? Sure, protein, lipids, and you may see some red blood cell casts as well, but usually a small amount. That is different than nephritic syndrome. The primary characteristic of nephritic syndrome is hematuria due to a high level of red blood cell casts. And this results in urine that is smoky or tea-colored. Individuals with nephritic syndrome will have protein in the urine, usually somewhere between 1 and 2 grams, and they will have edema. However, their edema tends to be more peripheral and less central, simply because of the amount of protein that they're losing. Nephritic syndrome is more likely to be associated with a true inflammatory-based disorder. So you are more likely to see this in the IgA nephropathy in children. You may see this in a rapidly progressive glomerulonephritis until it becomes very severe, and then it may, because as rapidly progressive becomes severe, they can become nephritic. Or this can be after an infection or after an upper respiratory infection. Hypertension is frequently associated with nephritic syndrome, and part of this is due to vasoconstriction and stimulation of renin-angiotensin-aldosterone. Once again, manifestations that we would look for would include a decrease in the urine output, but their levels of azotemia, that elevated urea nitrogen, and creatinine tend to be less pronounced than what you'll see in nephrotic syndrome. The end result of this nephritic syndrome is glomerular cell sclerosis, and the membrane becomes damaged. So it isn't without risk and isn't without damage. It just gets there in a different way. But what I really want you to be able to do is can you see the similarities but also the differences in nephrotic versus nephritic syndrome. I would focus on the level of protein, presence of hematuria, the casts in the urine, as well as the manifestations of the lipids as well as the azotemia, because they are different in these. So what about tubular interstitial disease? Well, tubular interstitial disease, like glomerular disease, can be acute or it may be chronic. So when we're looking at acute versus chronic, we are looking at the rate of deterioration, whether or not the glomerulus has become involved, and whether or not the vessels are involved. So let's talk through that specifically. In an acute interstitial, tubular interstitial disease, there is a rapid deterioration of the tubular of the tubular mechanism. Lymphocytes tend to invade the tubules, but the glomerulus and the vessels are spared in this pathology. So in an acute disease, it happens rapidly, but the glomerulus and the vessels are spared. In chronic tubulointerstitial disease, this happens slowly, and it's characterized by fibrosis and atrophy. It does eventually affect both the glomeruli and the vessels as it is long-term and isn't corrected. So when we're looking at tubular interstitial disease, we're looking at whether or not it affects the tubule, the interstitium, and both. So if the tubule is affected, so let's focus on the tubule being affected. If the tubule is the only thing affected, the basement membrane, which is damaged. Let me start over. In a with the tubule is affected, you're looking at whether the basement membrane or the tubular epithelial membrane has been damaged, and this is important. When the basement membrane of the tubule has been affected and damaged, the tubules are less likely to recover function. If the tubular epithelial membrane has been damaged, the structural integrity of that tubular system has been maintained and has a higher likelihood of recovery. When the interstitium is affected, remember that the interstitium is the area between and among the tubules, and that area can become inflamed and necrotic. So what happens when there are two ways by which the interstitium can be affected. Substances can actually leak from the tubular lumen into the interstitium itself. So when that happens, then you would have damage to the tubule that is now leaking into the interstitium. The second thing that happens then is that the pressure increases in that interstitium, effectively collapsing the tubule or affecting its ability to function. So that area between the tubules can be affected because the tubules led to the damage, or that damage, that area between can become inflamed and then become necrotic. In both of these processes, tubular as well as interstitium, it results in transport abnormalities. Remember what the tubules do. The tubules are responsible for reabsorption, secretion, and excretion. So in a tubular interstitial disease, we're going to look for things that we know could and do show up in the urine, but they're there in larger quantities, or they're not being effectively managed, reabsorbed, or even changed by the tubular mechanism. The last thing I wanted to say remember to say about chronic tubular interstitial disease is because of this slow deterioration, clearly someone can have this damage for over time before someone would know that they have this damage. You'll see tubular interstitial disease in someone who has taken a lot of nonsteroidal anti-inflammatory drugs. This can be a component of lupus nephritis, and this is what happens in chronic pyelonephritis as well. So if we look at the urinalysis itself, remember, poor man's biopsy, we can actually then take that to the level of comparing glomerular versus tubular disorders. So if you look at the amount of protein, you can see a lot more protein in a glomerular pathology as opposed to a tubular pathology. We can look at that albumin to creatinine ratio much more effectively in a glomerular pathology. In a tubular pathology, we might want to look for eosinophils because that would tell us that the tubules are undergoing an allergic response. When we look at urinary sediment, if it's a glomerular disease, we're going to look for glomerular casts, cast-off cells. In a tubular pathology, we would look for tubular and tubular epithelial casts. We may see red cell and white cell casts in glomerular. You'll see white cell casts and a much larger amount of red cells themselves, or red cell casts in tubular, so the volume would be higher. The other thing you'll see in a tubular disorder, as this gets worse and worse and worse and worse, are broad, waxy casts. These are a collection of these casts, these cast-off materials that have formed little bricks within the tubular lumen, and this is a very late sign of tubular damage. And then, as we talked about in the introductory lecture to the renal piece, we can use urinary biomarkers, and this is the promise of being, once again, when we look at urinary biomarkers, especially for acute injury, we can determine whether this is a glomerular or a tubular dysfunction. So in this time together, we've talked about some, primarily the difference between glomerular and tubular diseases. Can you describe the differences between the two? Can you look at a urinalysis and differentiate them? Because that's really one of the things you want to take a look at. When you look at nephrotic versus nephritic syndrome, what's the difference in the distribution of the edema? In addition to what you would see in the urine. Are there different pathologies that tend to lead to a nephrotic versus a nephritic syndrome? And then also remember to take a good look at calculi, at nephrolithiasis. Remember that although these stones develop within usually that collecting duct, the pathology is frequently silent until it gets big enough for it to want to move on down the road. And so when the body tries to either pass that stone, or the stone gets so big that it starts obstructing something that you desperately need to be unobstructive, you may not see any symptoms. I hope this information has been helpful, and I also hope you'll let me know if you have any questions. Thank you.